on Dr. Friedman's presentation, and we wanted him to have plenty of time to comfortably develop the background and the results of the study. Sovah Health is accredited by the Southern States CME Collaborative to provide physician Category 1 CME and by the Virginia Nurses Association to provide nursing CE credit. This program was developed to promote two physician desirable attributes, that of patient-centered care and our employing evidence-based medicine in practice. As is the case for all of our CME programs, we ask our speakers and planners to disclose any commercial relationships over the past 24 months prior to the program. Dr. Friedman reported he is a consultant and has received a research grant from AstraZeneca, and that he and Wake Forest School of Medicine share the patent for APO1 testing, genetic testing. A mitigation plan was developed to manage these relationships with him. He was kind enough to let us review his slides before the presentation. There was no evidence of commercial bias. In addition, he attested that any recommendations he will make to you in the care of patients will be based on evidence-based medicine from peer-reviewed literature. They'll be free of any commercial bias, and that it will be from consensus-generated guidelines. Myself and members of the Sovah CME committee have nothing to disclose as far as relationships. There's no commercial support for this program. The program is supported through an educational grant from the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, who founded Southside Urology, also known as the Danville Urologic Clinic, created this fund upon his retirement, and it has been a major supporter of CME, not only for physicians, but other allied healthcare professionals, including nursing, EMTs, and dental professionals in our community. You will this evening receive an evaluation form that will be emailed to you, or you can get it through a link I'll share with you in just a moment. On that eval form, you'll be asked to re-enter your name as well as your email. Please give us your full name, in as much as what you enter here will be on the CME certificate you subsequently receive. Please do not use any nicknames or short names, in as much as when that happens, Mary Kent and Van Holt have to basically backtrack to try to determine the name for the certificate. If you are sharing a log-on this evening with another individual, which is fine, and we're glad to have everyone, please let Mary know that so we can give credit to the other person who may be sharing the log-on on which you are currently listening. We also will provide to you in the chat box at the end of the program a QR code that you can click on this, which will take you to the evaluation form. If you prefer this to the CME email that you will receive. If you click on the code, you won't receive the email. But we urge you to use this if that's something that's more to your liking. As far as CME certificates, we like to remind our residents that you do not have to track your CME certificates. We notify your coordinator, that's Dara Johnson and Lori Galvez, of your attendance, and they keep up with that for you. Otherwise, you will get a CME certificate emailed to you once you submit the eval form. For our nurses and nurse practitioners who are on the program this evening listening, which we are delighted you're here, please know that you must submit an evaluation form in order that you receive the CME or CE certificate for your participation. For other allied healthcare professionals, you may be able to submit the CME certificate we send to you to your respective professional organization to get credit within your area of practice. I like to always at this point thank Mary Kent and Van Holt for helping develop this program. Quite honestly, they do most of the, if you will, heavy lifting that allows the many documents to be completed, and without their help, we would not be able to have the programs that we're so pleased to present to you. I know Dr. Friedman encourages questions and comments, and we hope that'll be the case this evening. You can raise your hand electronically, and Mary will see that. Or otherwise, he'll be at times be asking for questions. Please speak up. Mary also will be monitoring the chat, and she'll funnel those into Dr. Friedman as he does his presentation.
You're back
Dr.
in
Moore,
mute.
Dr. Moore, you're muted again.
Do that, yeah. I'm sorry. I don't know when that happened. I'm not doing that. I'll have to just watch it, I guess. Questions are encouraged. When you ask a question, please mute your phone so we don't get feedback. And we urge you to provide as many questions as you have or you come up with. I want to highlight for you a couple of upcoming programs, which we hope you'll be able to attend. On Thursday, April 24th, we will have a value medicine and inpatient care program. Dr. Pawa, who is a hospital medicine physician at the Johns Hopkins Hospital, will be doing this. He has been a leader nationally in defining the value of what is known as value medicine. Value medicine is a determination that it is worth doing whatever specific diagnostic test or therapeutic interventions are best for the patient. So many times we draw excessive blood tests or do excessive radiology, repeat studies, and there's evidence-based medicine about what those optimal numbers are and how that can improve patient safety and actually help the overall healthcare system provide better care. Following that in May, as you may know, is National Stroke Awareness Month and High Blood Pressure Control Month. We'll have two programs, one on May 22nd, which will be Dr. Dylan Ryan from Duke Neurology, reviewing with you the updated American Heart Association guidelines for primary stroke prevention. And then following that, a week later, Dr. Husseini, who is the director of the Duke Telestroke program, will be reviewing any recent changes on acute stroke management and providing some follow-up information on our experience at Sovah Health, both at the Danville and Martinsville campuses, on our patients' experiences with the Duke Telestroke program. For any on the call that may not be aware, we do participate with the Duke Telestroke program, which has been a remarkably helpful and very good thing for our patients who present with acute stroke syndromes. And then finishing out the first half of this calendar year, in June, we'll have a program on the diagnosis and management of dementia. This by Dr. Andrew Liu, a neurologist at Duke, Dr. Francis Walsh, one of our CME committee members, and a neurologist is going to be moderating that program for us. That leads me to introducing our speaker. I just cannot tell you how delighted I am to have Dr. Barry Friedman as our speaker this evening. Dr. Friedman is a nephrologist at Wake Forest University School of Medicine, where he actually is the chief of the nephrology section and holds the John H. Phelps, or Jack Phelps, as some of us knew him, a chair of internal medicine in nephrology there. Dr. Friedman originally was from Brooklyn, New York, and he attended his undergraduate experience there at the City University of New York, graduating summa cum laude in biology for his bachelor's degree. He then went to the Downstate Medical Center of the State University of New York for his MD, where he was selected as a member of Alpha Omega Alpha. As I'm told this group so many times, that is the Honor Society, Academic Honor Society. For medical students, a really remarkable honor. He then did his internal medicine residencies at Eastern Virginia School of Medicine, and that was followed by a fellowship at Wake Forest in nephrology. Dr. Friedman has been at Wake Forest since that time to the School of Medicine and university's benefit. He's had a remarkable career rising through the academic ranks to his current endowed chair position and himself being a tenured professor of medicine nephrology there. He has received teaching awards at every institution at which he worked over his professional career. He's authored 12 book chapters and remarkably published well over 600 peer-reviewed articles, many in high-impact journals. He also has had numerous NIH R01 grants, which, if you're in academic medicine, is in and of itself a remarkable accomplishment. Over his career, he has evolved into a worldwide expert on the genetics of kidney disease. One of the reasons we brought him this evening to talk with us is that recently he was a co-author of a major article in the New England Journal of Medicine discussing a specific gene, the APO1 gene, and how it relates to progressive kidney disease. You may or may not be aware that our area, Danville, Martinsville, Southside Virginia, has an extremely high number of patients with end-stage renal disease. In fact, we're second in the state of the number of patients needing renal replacement therapy, only second to Henrico County near Richmond. Many patients here have renal disease, and I know that everyone that's on the call that either is directly involved with renal care or as a primary care physician, this is a huge part of your practice. So our understanding, what is now emerging as a whole new understanding of the risk of renal disease, is one of the reasons we're so delighted to have Dr. Friedman with us. So Dr. Friedman, thank you so much. I will step aside, and we appreciate your being here. Thank you.
Mike, thank you so much for that wonderful introduction. I have to tell you, it's a joy to be able to present for everyone at Sovah. And I also want to shout out my friend James Starling, I see is on this call. So Dr. Moore and Dr. Starling, you have some legendary nephrologists on this call. And when I was a fellow at Wake Forest, 1987, 1988, I remember going to the Danville Urologic Clinic and having dinner with Dr. Moore. I think somebody may need to mute if I'm not mistaken. Yeah, okay, thank you. All right, so as Dr. Moore said, these are my disclosures, and this is going to be a fun talk tonight. This is something I live for, love to talk about, and I'm going to tell you a story as this all developed and be happy to take questions along the way. So, we're talking about genetics of kidney disease. I'm going to share with you the story about the most powerfully associated gene in any common human condition, which is the APOL1 gene. But before I do that, I want to share with you some of the other genetics of kidney disease. Genetics, revolves around family clustering of disease. And in my house at dinner, when my kids were growing up, they would hear me talking every night about this gene and that gene. And we saw this ad when we were in Europe. My kids said, "Dad, this family clearly has kidney disease." Actually, what it was an ad for using the subway, the train in Brussels, because there were no bathrooms on the cars. But it took this family clustering of kidney disease to suggest to us that there might be an inherited basis for kidney disease. Now, you're all basically in primary care. We have nurse practitioners, physician assistants, residents. We don't expect nephrologists, specialty physicians do not expect you to recognize every rare syndrome out there. But the key is to recognize patterns where you may need to refer somebody to a specialist. So if you have somebody you're treating and they have high calcium levels and kidney stones, and they tell you, everyone in my family, aunts, uncles, cousins, grandparents have kidney stones, and a lot of them were told they have a high calcium, you'd probably refer them to endocrinology or nephrology to get them evaluated and find the genes. So family history of kidney disease is a very important part of the history you should be taking. And if somebody tells you, I have several people in my family on dialysis or with loss of kidney function, and they're all in my generation, they're all my brothers and sisters, but we don't know of anybody else in our family, that might be a clue that it's an autosomal recessive disorder, where you need 2 copies of the causative gene to cause disease. And remember, when you find somebody, the first person in a family, you're going to think it's a sporadic case. Oftentimes, you have to look at the family and say, can we get the creatinines, the urinalysis for urine protein in your relatives when they went to their primary care doctor for their annual visit? If you know that the parents have a consanguineous relationship, you may suspect autosomal recessive inheritance again. But if somebody says, many generations of my family, my grandparents, my parents, aunts, uncles, my brothers and sisters and cousins have a disease, that might suggest autosomal dominant inheritance. Age at onset of kidney disease is important, as I'll show you in a minute. Ancestry is important because the APOL1 gene story, which I'm going to tell you, basically is limited to people from sub-Saharan Africa, African Americans, Afro-Caribbeans, people in Brazil with African ancestry, and on the continent of Africa. Those are the folks who are at risk for APOL1 kidney disease. Caucasians, Hispanics, and Asians are not. So sometimes knowing that will help. Knowing what a kidney biopsy shows may give you clues. And just remember, I tell people, sometimes we test for gene variants and everyone in a family with a disease has it. And sometimes a few people in the family can have the variant and not have kidney disease. That's called incomplete penetrance, and that can fool you. So, critically, I think you just want to know, when should you be looking for a genetic basis and maybe consider referring someone. Now, what I would never do to you is give you a talk at 7 o'clock at night after a long day at work with long lists. I don't do that. I think we should teach in a way we can understand it and remember things. So for those of you who don't think about this often, the kidney is a blood vessel. It's a very specialized blood vessel. It has, a renal artery and a renal vein. The renal artery brings blood to the kidney, branches down smaller and smaller until you get to that thing you all know about called the afferent arteriole that brings blood to the glomerular capillary, and then it goes back out through the efferent arteriole. And you know this because when you give someone with kidney disease an ACE inhibitor, it blocks production of angiotensin 2, and you open up the efferent arteriole, the back door. The pressure in the glomerulus drops, proteinuria goes down, and we think that helps slow progression of kidney disease. Also, if you have people with diabetes and diabetic kidney disease, they often have heavy protein in the urine, high pressure in the glomerular capillary, which damages things. So you may want to prescribe an SGLT2 inhibitor. And SGLT2 inhibitors close the afferent arteriole. They narrow the afferent arteriole that brings blood into that glomerular capillary, and that drops the pressure and reduces proteinuria. And this glomerular capillary is a very leaky capillary, and it's meant to be leaky so that you can filter things like all the extra salt you take in and water you drink to get rid of toxins like urea and creatinine. And when blood is filtered from that glomerular capillary into the urinary space, and I hope you can all see my pointer, that's the formation of urine that we excrete from the body. But the most important cell in this glomerular capillary is listed as the podocyte, and many of you may never have heard of that. That's the cell that covers the glomerular capillary and allows a lot of the barriers to losing protein in the urine and protecting us from keeping things we want in the bloodstream, preventing them from getting filtered. And this is a scanning electron micrograph of the podocyte, and you see the shape it has. Underneath that cell is the glomerular capillary, and you see all these little gradations in the cell. Those are filtration membranes where things that are going from the capillary into this urinary space have to get through those. This is a very special cell only present in the kidneys. And this is a diagram I want you to see. These bumps are the same as these bumps. So this is the capillary here. And inside the capillary, you see our red blood cells, our albumin. These are things we don't want to leave the capillary. We want them to stay in the body. But the things we want to get out from the capillary into the urine, the urinary space, excess salt, excess water we take in, and toxins like urea and creatinine. So there's the capillary endothelial cell, which is an fenestrated endothelial cell. On top of that is the glomerular basement membrane. You've all heard of the glomerular basement membrane, and that's made of collagen type 4. By the way, there's a disease of collagen type 4 mutations called Alport syndrome. And if you see somebody who has hematuria, gradual loss of kidney function, hearing loss, and ocular problems, ocular abnormalities, that should make you think this could be Alport syndrome. And you'd want to know, do other people in their family have it? That's from mutations in the collagen 4 chains, the alpha chains in collagen 4. So to filter into the urinary space, you've got to get across the capillary membrane, the glomerular basement membrane, and then that specialized podocyte layer. And I've only listed a few critical genes I just want you to have heard of. There's genes called nephrin and podocin, and they form the barrier, the slit that protein is repelled by and stays in the capillary, and other toxins can pass through. Mutations in nephrin and podocin cause proteinuria and kidney disease in children. There's the Wilms tumor 1 gene, the WT1 gene, which can cause kidney disease with mutations in children and adults. And then there's adult forms of kidney disease with proteinuria, the alpha-actinin 4 gene, inverted formin 7 gene, and the TRPC6 gene. So there's hundreds of proteins in these cells, but these 7 cause most of the kidney diseases that you'll see commonly. And of course, I've got ApoL1 separate. This is going to be for the second half of the talk. But the major kidney-limited forms of kidney disease that are genetic and run in families, and you see somebody with protein in the urine, a low GFR or high serum creatinine concentration, you should start thinking, could this be one of these diseases? You know, in children, we see a disease called congenital nephrotic syndrome, or nephrotic syndrome of the Finnish type, where children in the first few days and weeks of life have massive edema, hyperlipidemia, heavy proteinuria, and they're very, very sick. We now know that in Finland and throughout the world, mutations in this nephrin gene are very common. And there's nephrin right there. That's the slit barrier, and nephrin keeps albumin in the bloodstream. But if you have a variant in that gene, the albumin leaks through and you get nephrotic syndrome. And what supports nephrin in that space between the podocyte humps? Podocin. Well, that's the next gene right there in children. So if you have autosomal recessive mutations in nephrin or podocin, that accounts for a large percentage of chronic kidney disease with proteinuria, and the lesion often looks like FSGS, focal segmental glomerulosclerosis. I'll show you a picture of that in a minute. But in kids, these are the genes you should think of. If you're a pediatrician or you have kids in your practice, you want to get them to a nephrologist quickly to look for these mutations. Now, in adults who have heavy proteinuria and loss of kidney disease, you know, FSGS, 17% of FSGS in adults is from autosomal dominant mutations in the inverted formin 2 gene, INF2. 12% are due to alpha-actinin 4, ACTN4, autosomal dominant, and TRPC6. And, you know, I see you have a number of speakers coming from Duke in the coming weeks. The TRPC6 gene was discovered by Dr. Michelle Wynn, a leading nephrologist at Duke. Unfortunately, is no longer with us, but she described that, and 3% of cases in adults. So basically, 30% of FSGS in adults that runs in families, the familial type, is caused by the mutations in these 3 genes. And these genes are all located in these podocytes. So it makes sense when you think about it. The apolipoprotein L1 gene is autosomal recessive. This causes a third of all chronic kidney disease in African Americans. So if I were to walk into a dialysis unit in Danville or Winston-Salem or Chicago, Los Angeles, Cleveland, or Birmingham, Alabama, doesn't matter. 1 out of every 3 African American patients on dialysis in any of those units is on because of mutations in the ApoL1 gene, apolipoprotein L1. And I'll tell you the story of how we got it. And lastly is the Wilms tumor 1 gene. And, you know, in young adults, it can be a cause of FSGS. And in children, it can cause Denise Drash and Fraser syndromes, where they have abnormal external genitalia, chronic kidney disease, and proteinuria. So, you know, I don't want you to remember a big long list, but if you see familial clustering of kidney disease in children with nephrotic syndrome, adults with heavy proteinuria, that's when you may want to think of referring them to a nephrologist. A nephrologist can test a panel of genes and find the causative mutation. So ask about the family history. And this takes me to the most powerful gene in human disease, just happens to be a kidney failure gene. And I want y'all to think about your clinic this morning. Think about 9 o'clock this morning, you were sitting there, you had 12 people to see, and a 40-year-old African-American woman with high blood pressure is referred to you for stage 3 chronic kidney disease. They say, the creatinine's up, we need somebody to look at her. Her serum creatinine is 1.38. That's really doesn't look that high, does it? But when you're a 40-year-old woman, that's very high. And her estimated glomerular filtration rate, by plugging a creatinine of 1.38 into a CKD epi equation in a 40-year-old woman, says her glomerular filtration rate, her kidney function, is already 50% reduced. She's lost half her kidney function. And I'm willing to bet that other than Dr. Starling and Dr. Moore, few people on this call would get excited about a creatinine of 1.38, but we should, and you should look at the GFR. The urinalysis is normal. There's no blood in the urine, no protein in the urine. She's on an ACE inhibitor and a thiazide diuretic. She's a school teacher in Danville. She doesn't drink, she doesn't smoke, no illicit drugs. She mentions she had a grandfather on her father's side and an uncle on her father's side on dialysis, but she doesn't really know much about it. Her exam is normal except for a blood pressure of 136/88. And her lab testing, she has a normal A1C, her anti-nuclear antibodies, hepatitis and HIV tests are negative. You do a very, very sensitive test for albumin in the urine, a urine albumin creatinine ratio, and it's perfectly normal, 10. And you get a renal ultrasound because she lost 50% of her kidney function. Her kidneys are 8.8 centimeters bilaterally, and the radiologist said slightly hyperechogenic kidneys. So if I were to ask everyone in the room today, what's your diagnosis? I'm betting that most of you would say, oh, well, she's no protein in the urine. She has high blood pressure. Clearly, this woman has hypertensive nephrosclerosis. And what I'm going to do is I'm going to raise her dose of ACE inhibitor because that's a renal protective medicine. I'm going to get that blood pressure a little bit lower into the normal range, and she'll be fine. And I want to show you what's going to happen if that's your management. This is that patient, 40 years old, 3 years later. She's now on dialysis, just like her paternal uncle and grandfather. And the reason is she doesn't have hypertensive nephrosclerosis. She has ApoL1-mediated kidney disease, which is often mistaken for hypertensive kidney failure. So I want to show you the glomerular capillary. This is another picture of that glomerulus that I showed before. This is a real histology, an H&E stain. So this is the glomerular capillary. Do you see there are red cells inside the capillary lumen? So this is the inside of the capillary. It's got a filter across the glomerular basement membrane and the podocyte to get into the urinary space. And this is a beautiful, healthy, normal glomerular capillary. This is what your patient has, the 40-year-old woman who had a GFR of 50 from ApoL1. This doesn't look normal at all. This is what we call solidified glomerulosclerosis. The glomerulus looks like a cannonball. It looks like a solid mass with some nuclei in it, and there's no capillary loops at all. So there's no filtration occurring. So you might say, well, why doesn't this patient with a glomerular disease have protein in the urine? You did a urine albumin to creatinine ratio, a very sensitive test, and there's no extra albumin in her urine. Well, there's no capillaries that are open to filter the blood. How can she lose anything in the urine? This glomerulus is non-functional. Nothing can leak because blood's not getting through it. The other lesion these patients get is what we call focal segmental glomerulosclerosis. So this is a glomerulus, and I want you to see that this part here on the left is perfectly normal. But up here at, 12 o'clock to 3 o'clock, and I've got something in my way. Let me move this here. From 12 to 3, it's a scar. So this is a segment of this glomerulus has a scar, so it's segmental, and it's focal because not all glomeruli have this, and that's the disease we call FSGS, focal segmental glomerulosclerosis. And in African Americans, it occurs much more often than we see it in the white population, Asian or Hispanic populations. Let me just advance here. Okay, so in the United States today, if we look at the causes of ESRD that nephrologists list, which, these are people, most of whom don't get a kidney biopsy, 48% of people starting dialysis today in our registry are listed as diabetic kidney disease. 29% as listed as having hypertension as the cause of their kidney failure. What's really amazing is in Black patients, more than 35% of Blacks starting dialysis are listed as having hypertensive kidney disease, like the patient I showed you today. And
Dr.
if we
Freed,
look, yes, ma'am.
sorry, we have a question in the chat.
Sure.
Okay. Is the apolipoprotein the same that causes heart disease in active, healthy people?
No. So there are circulating lipoproteins in the blood, like HDL cholesterol and things like that, change your risk for heart disease. High HDL is protective. Low HDL puts you at risk for atherosclerosis. This is different. This is the apolipoprotein L1 gene. And the ApoL1 protein is important in the immune response, as I'll show you in a minute. ApoL1 independently does not cause heart disease, stroke, or anything like that. But when you get kidney disease from ApoL1, any kind of kidney disease can increase the risk of heart attack and stroke, but it's not from the ApoL1 gene. It's from having kidney failure. Okay? Any other questions, Mary? Okay. All right, I'm going to continue. So by the way, this now is the rate of end-stage renal disease in different population groups. So African Americans are up here. There are 900 new cases of end-stage renal disease per year in African Americans, but Caucasians, American Indians, Asians, it's 300 per thousand. So the Black population has 3 to 4 times more kidney failure than Caucasians and other populations. And most of that extra risk comes from the ApoL1 gene, which we're talking about. It doesn't come from saying, oh, the blood pressures are too high, or they're non-compliant with their medicines, or they don't have access to health care. I mean, a lot of these things are true. Minority populations often don't have equal access to health care. That's a terrible thing, and we all have to work to improve that. But the reason African Americans have 3 to 4 times more kidney failure than others is not environmental. It's biologic from this ApoL1 gene. So the things I want you to take home today are that the vast majority of reported causes of non-diabetic kidney disease in the United States are wrong. Hypertension is not the cause. I'll show you why. That ApoL1 mediated kidney disease is the most powerful genetic association in any common disease, and it's changing nephrology and transplant, as you'll see. And inflammation and the immune response play important roles in susceptibility to kidney disease. And I've been screaming this for years. I've talked about we need to reclassify the causes of kidney disease in our registry because they're so often wrong. And I've really questioned, does high blood pressure cause kidney disease? The answer is no. So let me tell you how this came. This goes back to the family clustering of kidney disease. And Dr. Moore will remember some of these papers from the early 90s. This is a paper we published in the American Journal of Kidney Disease, where there are Black families that have multiple members on dialysis. And everybody in the solid squares and circles has end-stage kidney disease on dialysis. So these are families that cluster kidney failure. These are not stick diagrams to me. I remember these families. I took care of these patients. And I want you to see, this is a family with 3 different types of kidney failure in one family. Here's a family with 3 brothers on dialysis and one of their children with 4 different causes of kidney disease. 3 different kidney diseases. 3 different kidney diseases. This was common in the Black population. We never see this in the white population. In the whites, if one patient has kidney failure from IgA nephropathy, everyone in that family has IgA nephropathy or diabetic kidney disease. Everyone else in the family gets diabetic kidney disease. But in Black families, we often saw 3, 4, 5 different types of kidney failure. Sometimes it was listed as hypertension, sometimes lupus, sometimes HIV nephropathy, or that FSGS I talked to you about. And we proposed, based on these families, that there was a single gene that could cause many different types of kidney failures based on the environmental trigger. And what was true in almost every family is that there was one member listed as an A, just like the patient I presented to you, who presented with high blood pressure, kidney disease. They didn't have any diabetes, and they had very little protein in the urine, and everybody called them hypertensive kidney failure. And we said, nope, nope, nope. They're in these families. This is a genetic kidney disease. And, we have plenty of time tonight. Dr. Moore extended this. I just want to tell you, doctors didn't listen to the patients. Our patients knew this. I had young African-American men, 25 years old, refer to me for high blood pressure. And the blood pressure might be 150 over 95. And I would do a thorough evaluation. The urinalysis was fine. Their kidney function was fine. Their thyroid tests were fine. And I would tell this young patient, don't worry, you have essential hypertension. I've got a very special blood pressure pill, an ACE inhibitor. This will lower your blood pressure and you'll be fine. And many of those young men said to me, Dr. Friedman, I have one question. When do I need to start dialysis? And I would just about fall out of my chair. I would say, I just told you have hypertension. There's nothing at all wrong with your kidneys. And they'd say, Doc, you got to believe me. This is the way everyone in my family starts. They all start with high blood pressure at this age, and 5, 7, 8 years later, they're all on dialysis. So our patients knew what was going on, and the doctors wouldn't listen. The other thing we did, this is 4 separate papers. I found African Americans who had very severe hypertension, and they had no protein in the urine and normal kidney function. And I said, how many of you have a relative on dialysis? Oh, about 8.5% of them did. I found African Americans with long-standing type 2 diabetes. They had very high hemoglobin A1Cs. They had high BMIs. They often smoked and had high cholesterol, but they had normal kidney function and no protein in the urine, even with all those risk factors. And I said, how many of you with diabetes and no kidney disease have relatives on dialysis? They said 7%. I found blacks with lupus. And lupus is a systemic disease, and about half the people with lupus get kidney involvement, half never get kidney involvement. And I found African Americans with clear lupus, anti-nuclear antibody positive, and who didn't have kidney failure. And I asked about relatives. None of them had a relative on dialysis. And I found blacks with HIV-associated nephropathy. Now, this is from the 1990s, before we had highly active antiretroviral therapy. So there was no treatment for HIV back in those days. And the ones who had HIV but no impact on their kidneys, no protein in the urine, no low GFR, 6% had a relative on dialysis. So what I want to show you is if you don't have kidney disease, just having high blood pressure, diabetes, lupus, or HIV infection, the risk of having a relative on dialysis was about 7%. That's the lifetime risk for kidney failure in all African Americans. 7% of all African Americans will be on dialysis in their lifetime, and about 2% of whites. And if you say 7% divided by 2%, that's that 3 to 4-fold, 3.5 times extra risk for kidney disease in the black population. But what was shocking was when I found blacks who were on dialysis, who everybody thought had hypertensive kidney failure, and I asked them about relatives on dialysis, 40% had a relative with end-stage kidney disease. So this is not just having a relative with protein in the urine or a little bit of reduced GFR. These were relatives that survived chronic kidney disease and made it to dialysis, 40%. Type 2 diabetes with kidney disease on dialysis in blacks, 37% had another relative on dialysis. Look at the difference. Lupus, 28% of blacks with lupus nephritis on dialysis had relatives on dialysis. And HIV infection, nearly a quarter of blacks with HIV-associated nephropathy had relatives with end-stage kidney disease. Now, many of these relatives had a different form of kidney disease than the index case in their family. But I show this just to remind you that just having hypertension doesn't necessarily trigger the kidney disease. It's the people from those families. And, we wrote this very important paper in 1995, a review paper called The Link Between Hypertension and Nephrosclerosis. Now, I submitted the paper in 1993. It didn't get published till 1995, and I'll tell you why. This is the abstract. And this abstract was groundbreaking at the time. We said hypertensive nephrosclerosis does not commonly initiate kidney disease. Genetic factors cause the kidney disease The hypertension was secondary to the kidney disease in the Black population. And variation in one gene underlied many different kidney diseases in Blacks. And we proposed this as a hypothesis. So I submitted it in December of 1993. Here's my letter of rejection from the journal saying, after careful consideration, we regret we can't publish your paper. And we were really, really distraught. We were very upset. So one of the reviewers, reviewer one, sent me a 7-page review. And I just want to read to you some of the comments that this reviewer wrote. I'm limiting it to 2 because this reviewer had probably 25 comments. And he said, the kiss of death in a publication is the abstract is ho-hum, with nothing new or enlightening above what could be in a textbook. Now, I want to remind you, we said there was a genetic cause of kidney disease. High blood pressure didn't cause kidney disease. This was shocking to people. It was not ho-hum. And he said the diagnosis of hypertensive kidney disease was made without regard to the pathogenetic mechanisms causing the elevated blood pressure. What does this mean? If you know the pathogenic mechanisms, you should let us all know and make your trip to Stockholm for the Nobel Prize. This was the review of my paper. It was really a personal attack, not a fair review. And I complained to the editor, and they sent it out for review again. It took a year, and finally it got published. And for those of you who are curious, I have made my trip to Stockholm. I love Stockholm. It's a beautiful city. I haven't been there for the right reason, but I have visited. Okay. Now, I just want you to know that many of you, I'm sure probably everybody, you write on the chart every day you think your patient has hypertensive kidney failure or diabetic kidney failure. Those 2 diagnoses account for almost everything. But let's look at what happens in studies of patients with mild to moderate hypertension and the effect on the kidney. And there are some older studies before ACE inhibitors, before angiotensin receptor blockers, the Australian therapeutic trial, the Mr. Fit multiple risk factor intervention trial, hypertension detection follow-up program, HDFP. These 2 were NIH-sponsored studies. And then there's new studies, the SPRINT study, which was led by Wake Forest as the coordinating center, systolic blood pressure intervention trial, and the ASK study, African American Study of Kidney Disease and Hypertension. Both of these were prospective NIH studies, and they included ACE inhibitors and angiotensin receptor blockers. So the 3 old studies, I just want to make a few points. They looked at an endpoint of a creatinine going up to 2. Either in the Australian therapeutic trial, any creatinine of 2, in the Mr. Fit study, a doubling of creatinine to 2, and the HDFP, a 25% increase in creatinine to 2. Now, first of all, to get into the study, you needed a creatinine less than 1.5. Now, do you remember the patient I presented to you in our case? She had a creatinine of 1.38. She lost half her kidney function at that point. She could have been enrolled in these studies and been listed as having hypertension because they considered anybody with a creatinine less than 1.5 normal kidney function. Boy, is that wrong. And if you have advanced kidney disease and secondary hypertension, obviously you're going to be more likely to have your creatinine rise to 2. So the percentage of rise to 2 that I'm going to show you is obviously an overestimate because some of these people had kidney disease when they got in. And renovascular disease, which Dr. Moore knows all about, Wake Forest was a leading center studying this. They didn't even look for renovascular disease in these studies. So renovascular disease is like atherosclerosis of the large renal arteries causing renovascular hypertension. That can certainly cause chronic kidney disease and dialysis. They didn't look for that either. So the numbers I'm going to give you of how many people had a rise in creatinine to 2 are overestimates because of these inclusion criteria that, should have been tighter. So how many do you think in the Australian therapeutic trial had a rise in creatinine to 2? It was 1 patient per 1,000. That was 1,600 patients followed for 3 years. And by the way, the Australian therapeutic trial was observational. They didn't treat the patient's blood pressure. They left them with diastolic blood pressures of 90 to 109 for 3 years, and only 1 in 1,000 had a rise in creatinine to 2. And that's an overestimate. The multiple risk factor intervention trial, 1.4 patients per 1,000 had a doubling of creatinine to 2. This was an NIH study, 13,000 patients followed for 7 years. Half the patients got stepped care where they told the doctor, add this drug, add that drug, double the dose. Half of them were treated just usual care, whatever the doctor wanted to do. There was no difference in the doubling of creatinine to 2. But again, it was only 1.4 patients per thousand, and that's an overestimate. And then there's the hypertension detection and follow-up study. Now, this study included 20% African Americans who have genetic risk for kidney disease. 8,000 people, 20% of them were Black, 5-year follow-up, now 1.3 per 100, 1.3% had a rise in creatinine to 2. But aren't you a little shocked that in these big studies, the creatinine very rarely rose to greater than 2? But you could say, well, Dr. Friedman, that's before ACE inhibitors. It's a new day. Okay, you're right. So this is the SPRINT study from the New England Journal of Medicine, 2015. I'm one of, 1,000 co-authors on this paper. This is a landmark paper from the NIH, effects of lowering the systolic blood pressure to less than 120 or less than 140, and it had 9,300 people followed for 3.25 years, and lo and behold, lowering the blood pressure intensively to a target of less than 120 systolic significantly reduced fatal and non-fatal major cardiovascular events and all-cause death. It reduced MI, acute coronary syndrome, stroke, heart failure, cardiovascular death. So all of us in this room should be targeting a systolic blood pressure less than 120 millimeters of mercury to help our patients live longer. Well, what about the kidney? There was no significant effect on slowing the progression of nephropathy by getting the blood pressure down to 120 in people with existing nephropathy. And if you started the study without kidney disease, there was a significantly increased risk for developing a reduced glomerular filtration rate, GFR less than 60, what would put you in stage 3 kidney disease, that remained below 60 for at least 90 days. So, although lowering blood pressure is critical to preventing heart disease and death, and you should do it, and I do it, don't do it for the kidneys because it doesn't have an effect. And this is the table 2 from SPRINT showed 25% reduction in MI, coronary syndrome, stroke, heart failure, cardiovascular death, and, it's highly statistically significant. So this is table 2. This is the top of table 2. Here's the bottom of table 2. This looks at kidney disease patients. There were 1,300 people with kidney disease that had a blood pressure target of less than 120, another 1,300 with a target of less than 140. What was the p-value for change in, 50% loss of GFR, need to start dialysis or kidney transplantation? Non-significant. So if you had kidney disease and there were 2,600 people, lowering the blood pressure had no effect on the rate of loss of kidney function. You lost kidney function just as quickly either way. But what about the people who started the study without kidney disease? They had a glomerular filtration rate above 60 with no protein in the urine. There were 6,600 of those people. Half got the intensive blood pressure lowering, half got the target of less than 140. And what I want you to see is there was a 3.5-fold increased risk for the GFR falling below 60, a 30% reduction in GFR in the intensive group. If you tried to get the blood pressure down to less than 20, which we should all do, you have a 3.5 times increased risk of causing the GFR to fall. So if you think that you're protecting the kidneys by lowering blood pressure, I got news for you. It's not happening. And the most impressive study, very exciting, is the African American study of kidney disease and hypertension, the ASK study by the NIH. And look at the title of this study. Long-term effects of renin-angiotensin blockade and low blood pressure on hypertensive chronic kidney disease in African Americans. And this paper is published in the Archives of Internal Medicine. The title, Hypertensive Chronic Kidney Disease, is wrong because in this SPRINT study, it was 10-year follow-up, almost 1,100 people who they were Blacks who were thought to have hypertensive kidney failure. Strict blood pressure control failed to slow disease progression. And ACE inhibitor, calcium blockers, beta blockers had equal effects. None of them slowed progression. The ACE inhibitors were not kidney protective in this group. And there's the data over 10 years. The red line is African Americans that were put on a low blood pressure goal, high dose ACE inhibition. And this is the cumulative outcome of doubling of serum creatinine or dialysis. As you see, over 10 years, 60% of people in this study who were thought to have hypertensive kidney disease lost 50% of their kidney function or started dialysis. It was the blood pressure lowering and ACE inhibitor were not protective. I got the DNA from these people, and Mike Lipkowitz and I worked with the ASK group, and we took the DNA from patients who were thought to have hypertensive kidney failure, and we tested them for ApoL1, and it turned out all the loss of kidney function had nothing to do with blood pressure or ACE inhibitors. It had to do with the ApoL1 gene test of these patients. So we basically changed the whole paradigm of kidney disease. And this is the paper that showed it first. This paper's in Science in 2010. Martin Pollack from Harvard was the senior author. And here's our group. We actually contributed 84% of the DNA samples to this paper, which showed that the ApoL1 gene was what was causing kidney disease in African Americans. And the reason they're there is they protect from a parasitic disease in Africa called African sleeping sickness. By the way, this is a parasite in the bloodstream called a trypanosome. And these are red cells. And this is a patient with trypanosomiasis or African sleeping sickness. And there's 3 variants in this ApoL1 gene. There's the G0 or wild type variant, and then there's the G1 and G2 kidney risk variant. And these are coding changes in the gene. And what I just want you to see is if you get 2 copies of the risk variants, G1 or G2, excuse me, if you get 1 copy from your mom, 1 copy from your dad, whether it's G1, G1, G2, G2, or 1 G1 and 1 G2, that markedly increases the risk for chronic kidney disease, and it's autosomal recessive. You need 2 copies. And the reason we know it protects from this infection, which is why the G1 and G2 variants were common in Africa, is this is plasma from somebody with a G0 or the wild type variant, which is what all the Caucasian population, whites, Asians, Hispanics, were all G0. This trypanosome is perfectly healthy. It's swimming in plasma from somebody without a kidney risk variant. But if you take somebody with 1 G1 variant or 1 G2 variant, they're not going to get kidney disease because you need 2 copies. But if you just have the 1 variant and you take plasma, do you see the lysosome in the trypanosome is swelling? And that's because the G1 protein is inserting in the lysosomal membrane, causing it to rupture, and that kills the trypanosome. So what happened is 8,000 years ago on planet Earth, nobody had any G1 or G2 risk variants, and millions of people in sub-Saharan Africa died every year from African sleeping sickness. Then 8,000 years ago, these single mutations developed, G1 and G2, in the ApoL1 gene. And they were able to kill the trypanosome and protected people, from African sleeping sickness. So everybody without G1 and G2 perished from sleeping sickness, and the individuals with G1 and G2 passed them on. 8,000 years ago is when this all started. Think about this now. 52% of African Americans have either 1 or 2 G1 or G2 variants today. That's how powerful the positive selection was because it protected from sleeping sickness. And by the way, this is the same story for sickle cell disease and malaria. So African Americans commonly get sickle cell trait or sickle cell disease. Sickle trait is 1 copy of hemoglobin S. Sickle cell disease is 2 copies, 1 from your mom, 1 from your dad. Well, the reason sickle is so common is that 1 copy protected from malaria in sub-Saharan Africa. And people with hemoglobin S trait survived malaria, passed it on, and now 8% of African Americans have 1 or 2 hemoglobin S genes because it was positively selected for in Africa, protecting from malaria. Well, ApoL1 protected from trypanosomal infection. And we were the ones who first described the spectrum. This is what we predicted in the early 90s. One gene, many kidney diseases. So ApoL1 causes solidified glomerulosclerosis with very little protein in the urine, the disease wrongly labeled hypertension causing because the blood pressure went up secondary to the kidney disease. Focal segmental glomerulosclerosis, FSGS, with heavy proteinuria, ApoL1. HIV-associated nephropathy, or HIVAN. And many of you read papers when COVID came about that African people, African Americans, were getting collapsing glomerulopathy from COVID. It looked just like HIV-associated nephropathy, ApoL1. Nobody else gets HIVAN and COVAN except people with ApoL1 risk variants. So you can get kidney disease if you're white with HIV, but it's going to be an interstitial kidney disease. It's going to be from your antiretroviral therapy. It's not going to be collapsing glomerulopathy because only people with ApoL1 risk variants get this, and this has got heavy protein in the urine. Sickle cell nephropathy, severe lupus nephritis, and African American kidney donors who donate a kidney after transplant, those kidneys fail more rapidly if the donor has an ApoL1 high-risk genotype, which in the United States is 2 copies of the ApoL1 G1 or G2 risk variants. And this is the trypanosome in the bloodstream. This is the tsetse fly in Africa, and you see a stinger. The tsetse fly is the reservoir for the trypanosome parasite. And this is a canker sore on the leg of an African girl who's been stung by the tsetse fly, and it injects the trypanosome into her body. The trypanosomes enter the bloodstream, and they can kill you with African sleeping sickness. But if you have an ApoL1 G1 or G2 variant, you're able to kill off this trypanosome, survive African sleeping sickness, and pass it on to your offspring. It's a fascinating story. And these are patients you saw in clinic today who are Black and you thought may have had hypertensive kidney failure. This is an amazing story of evolution. So as I told you, this is the strongest, most powerful cause of any human common complex disease, just happens to be a kidney disease. 1 in 3 African Americans on dialysis have ApoL1 kidney disease. And in the United States today, 13% of all African Americans have 2 copies, and they're at markedly increased risk for getting kidney disease. More than 5 million African Americans, but that doesn't include the Caribbean, Brazil, the continent of Africa with hundreds of millions of people, and Europe, where there's people with African ancestry in all the European capitals. 39% of African Americans have 1 copy, so they're not going to get kidney disease, but they can pass that 1 copy on to their children, their carriers. Only 48% don't have any G1 or G2. So this is shocking. The ApoL1 gene is only found in humans and higher level primates like gorillas and baboons. So I want you to know many of my grants were rejected because they said, Dr. Friedman can't find genes in people. People are too complicated. I have the greatest rat model of kidney disease. It looks just like humans. I can find genes in my inbred rat and mice strains. Well, they'd never find the gene because the gene doesn't exist in rats and mice. You need to study humans. As I said, G1 and G2 are absent in everybody but people from sub-Saharan Africa. But what's interesting is only about 1 in 5 people with that high-risk genotype actually get kidney disease. There are modifying factors like HIV infection or anti-nuclear antibodies or COVID that trigger kidney disease. But 4 out of 5 people of that 5 million Americans with a high-risk genotype are not going to get kidney disease in their lifetime. So we're studying hard to find those second hits. And I'll just tell you that the bottom line is if these 2 risk variants in ApoL1 didn't come about 8,000 years ago, the risk of kidney disease in Blacks and whites would be identical. Blacks wouldn't have 4 times the risk of non-diabetic nephropathy. It would be 1 to 1. That's how powerful an effect this gene has. This is the article that Dr. Moore was referring to in the January 2025 issue of the New England Journal of Medicine. The H3 Africa Consortium looked at ApoL1 risk variants in patients from West Africa, which, by the way, has even higher frequencies of the risk variants than we do in the US. And in Africa, having one copy of G1 or G2 increased the risk, and that's a different environment. They're exposed to different factors. And you can see this is Nicole Palmer and myself. We did all the APOL1 genotyping for the H3 Africa Consortium. So in the US, it takes two copies, one from your mom, one from your dad. But in Africa, one copy can cause kidney disease. And we think you should be considering APOL1 genotyping in individuals with recent African ancestry, that's African Americans, who may be being considered to donate a kidney to relatives in their family, and they want to know, what's my risk for getting kidney failure if I donate? Well, APOL1 testing can be very helpful. We're going to show you the data. If you got an African American donor kidney, they're more likely to fail quickly after transplant from a deceased donor than if you got a deceased donor kidney from a white or a Hispanic or an Asian donor. And we showed at Wake Forest that it was the APOL1 genotype of the donor that predicted how well that kidney would do after transplant. Now I'm going to show you at the end of my talk some very exciting clinical trials targeting the gene. So if you have patients with diabetic or non-diabetic nephropathy that may be due to APOL1 and you know they have it, they can be enrolled in clinical trials that may stop their progression. If you have a patient with HIV infection or lupus or sickle cell and they're not compliant to their medicine, they won't take their heart therapy. If you test them for APOL1 and say, you've got two copies of the risk variant, if your HIV flares up and you get a high viral load, you're very likely to get kidney disease. You may want to be more compliant to your medicine. That may help those folks, and for family planning purposes. So let me share with you the data quickly in kidney transplantation. And I lead at Wake Forest. I'm the principal investigator of the NIH Apollo study, which is the APOL1 Long-Term Kidney Transplantation Outcomes Consortium, Apollo. This is a $50 million consortium being done at 140 kidney transplant programs around the nation. And it stems from this. This is a paper from 2002 showing that if you got a deceased donor kidney and the donor had African ancestry, like African Americans, or the donor was not African ancestry, other races, so European, Asian, Hispanic, this is the graft survival. The kidneys from Black donors failed much more quickly than kidneys from non-Black donors. It didn't matter the race of the recipient of the kidney. It was the donor. And look here, at 3 years, more than 25% of these kidneys had failed from the high risk, from African American donors. Only 10% failed from non-African. And nobody knew why those Black donor kidneys did worse. Well, this is our paper from the best transplant journal, American Journal of Transplantation. 136 deceased donor kidney transplant from African American donors at Wake Forest. And look here, this is the African American deceased donor kidneys who are high-risk genotypes, 2 copies of the G1 or G2 risk variants. And look here, at 3 years, half of them had failed. But if you got a kidney from an African American deceased donor who had 0 or 1 copies of the risk variant, those kidneys did great. They did just as well as kidneys coming from white donors. So we said, wait a minute, it's not that the Black donor was important, it's the genotype of the APOL1 in that donor. You can be Black with a low-risk APOL1 genotype, that kidney's going to do fine. And to tell you the hard story of my life, this paper was initially rejected by the American Journal of Transplantation. I called the author, the editor, who's Alan Kirk. Alan Kirk is now director of transplant at Duke. He's a friend. And he said, Dr. Friedman, I think we made a mistake rejecting your paper. Let me get it re-reviewed. Eventually, this paper that was first rejected now has been cited more than 300 times and led to the $50 million Apollo Consortium. People complained about this study because it was from a single center. So I reached out to my friends at Emory, Minneapolis, University of Alabama at Birmingham, and I got DNA from 624 African American deceased donors. And you can donate more than 1 kidney, you can donate 2 kidneys. So it actually led to 1,153 transplants from African American deceased donors done at 113 different transplant centers. And I want you to see, if you got the kidney from a Black donor with a high-risk APOL1 genotype, it was twice as likely to fail at 6 years than if your kidney came from a Black donor with a low-risk genotype. So we confirmed that it was the APOL1 genotype of the donor that determined the transplant outcome. The Apollo study, by the way, is looking at transplant outcomes and testing whether all African American deceased donors should have rapid APOL1 genotyping when the kidneys are procured. So, when somebody donates their organs, you have to do HLA typing from the donor. You have to test for HIV, hepatitis B, hepatitis C. Those are all PCR-based tests. In the same 2 hours that it takes to do HLA genotyping and HIV and hepatitis testing, you can do a PCR test and get the APOL1 genotype. And if it's a high-risk kidney that's more likely to fail quickly, you may want to give that kidney to an older person on dialysis who's not going to live, 30 more years because the kidney may fail. If you're 70 years old on the transplant list, that kidney's probably fine. But if you're 25 years, yeah, I'm sorry.
Dr. Friedman, we
yes,
have a couple questions in the chat.
sure.
Okay, this first one's kind of lengthy. I'll try and read fast. Good evening, everyone. Dr. Friedman, thank you for an excellent presentation, including a refresher on the histology of the kidney. Knowing that there is such a strong genetic predisposition for APOL1 that may ultimately be the etymology of end-stage kidney disease in African Americans and a significant segment of the population being negatively affected by the social detriments of health. What cost-effective suggestions, measures do you recommend to clinicians to enable them to get an early handle on this high-risk genotype in everyday practice? Thank you.
Great. So that's a great question. I think I'm going to cover it as we go through the rest of this talk, but I think if you're seeing somebody in clinic today or tomorrow and they look like they have hypertensive kidney failure, or they look like they have heavy proteinuria and a glomerular disease and they're Black, maybe they have other relatives in the family on dialysis, what I'm telling you is just simply lowering their blood pressure, putting them on an ACE inhibitor and an SGLT2 inhibitor, you think to yourself, I'm doing everything I can to protect their kidneys. But I'm going to talk in one more minute about ongoing clinical trials that directly target the gene. So if you test somebody who's Black with kidney disease and they have an APOL1 high-risk genotype, they may be eligible for being enrolled in one of these clinical trials, and that can cure them. All the other therapies we have today, some of them may slow progression a little, but like the patient I presented to you 3 years after the GFR was 50, she was on dialysis, and now she needs a kidney transplant. So I think that, first of all, getting to social determinants of health, everybody deserves access to care. I mean, there's no argument about that. Everybody should be freely getting tested for GFR, protein in the urine, serum creatinine. So once you find somebody with kidney disease and they're Black, testing for APOL1 may allow them to be enrolled in a trial. And that's why I think there's a role. But I'm going to wrap up with that on my last few slides, and I'm getting towards the end. Mary, were there any other questions?
The other one you kind of already answered, but specifically they wanted to know, as far as testing for APOL1, is there a specialty test that has to be sent to like a specialized lab?
Yeah, APOL1 testing is widely available. So you saw my disclosure. APOL1 testing is available at Wake Forest. It's available at Harvard. It's available at Arcana Labs in Arkansas. 23andMe, I hear, is going out of business. But if you get your genetic makeup tested at 23andMe, APOL1 is in there. So there are gene test panels available that test for 400 different kidney disease genes. APOL1's in there. So you can order APOL1 alone, or you can pay and get 400 genes tested at once, and they'll look for APOL1. But it's widely available. It can be ordered. All you have to do is Google APOL1 gene testing online, and all the places you can get it will pop up. Excuse me?
Yes.
Okay. Mary, can I go on?
Yes, you can.
All right. So now the question was what to do?
Let's get into bed.
So, when should you test people? Well, and I love this. This was a store named Jeans. The guy's name was Gene. And that was my first slide. And in the back, it said Gene's Discount. So I always joked if we ever found the gene that caused kidney disease, I'd open up a shop like this. But, when you have a genetic disorder, something wrong with your DNA, a mutation, you can re-edit the genome with CRISPR gene editing and fix the mutation everywhere. Well, we're not quite there yet. This is down the road. But the way DNA makes disease is it codes for a protein. And the ApoL1 risk variant proteins, G1 and G2, damage cells in the kidney. So, first of all, you can let the protein be made, and you can make an inhibitor of the protein, a small molecule inhibitor that blocks the effect of the ApoL1 protein on the kidney cells. And I'm going to show you data from a study in the New England Journal of Medicine that did that. Or the DNA first has to be transcribed to messenger RNA, and the messenger RNA is translated to the protein. There are antisense oligonucleotides that bind to and destroy the messenger RNA for just ApoL1 that prevent the protein from being made. These are already in clinical trials. You can enroll patients in them today. So basically, you've got DNA in the nucleus. This is for any gene, not just ApoL1, any gene. You make pre-mRNA, which becomes mature messenger RNA, migrates from the nucleus into the cytoplasm, translated to a protein, amino acids are put in a row, and you get a protein that has an effect. So if the protein's ApoL1, you can have an ApoL1 small molecule inhibitor that blocks that protein from getting to its receptor and doing damage. You can have an ApoL1 antisense oligonucleotide that destroys and targets the messenger RNA, preventing the protein from being made. And there are drugs that inhibit the pathway of ApoL1. Baricitinib, which is a JAK-STAT signaling inhibitor. This is a drug that is currently available to treat other diseases. It's being tested for a role in ApoL1 kidney disease. I'm only going to show you data from antisense oligonucleotides and small molecule inhibitors. So again, some of you tonight, this may be the first time you've heard of ApoL1, but this is the New England Journal of Medicine, 2023, using a drug called inaxaplin, which is made by a company called Vertex Pharmaceuticals, inaxaplin treatment of proteinuric kidney disease in people with two ApoL1 variants. Inaxaplin is a small molecule inhibitor of the protein, and these are patients who had kidney biopsies, and they all had that focal segmental glomerulosclerosis, FSGS, scarring in the kidney. And here's a cell in the kidney with its membrane, and ApoL1 protein is floating around that cell. It wants to bind to its receptor, but no, it can't, because the inaxaplin is sitting right in the receptor, blocking the ApoL1 from having an effect. That's the way this drug works. So what did it do? It's shocking. This study had 16 participants that had protein in the urine and kidney disease, and they had biopsy-proven FSGS, scarring in the kidney. Even in spite of the scarring, I want you to see in 13 weeks, there was a 44% drop in urine protein. Amazing. These are people who had kidney disease for years. You gave them an ApoL1 small molecule inhibitor. They had ApoL1 kidney disease. Bam, almost a 50% drop in proteinuria after just 13 weeks. And this is all 16 patients. 15 of the 16 had a drop in protein in the urine. Only one did not. And these 3 patients in the dark turquoise, they had nephrotic range proteinuria, very heavy proteinuria, more than 3 grams a day. This guy had a 55% reduction, this one a 50% reduction, this one a 35% reduction from nephrotic syndrome in just 13 weeks. So it shows, even if you've got scarring in your glomerular capillaries, if you can block the ApoL1 protein, you get rapid, marked reduction in protein in the urine. That's very exciting. That study by Vertex is enrolling now. You can get patients in it that are in your clinic. But if you're blind to thinking about ApoL1 and you blame it on hypertension, or you think your ACE inhibitor is protecting them, you're not fully protecting them. You need to get them into a clinical trial. The other therapy is antisense oligonucleotides. They bind to the messenger RNA. And this is a very exciting story. These are mice. Now remember, mice don't have an ApoL1 gene, but you can make a transgenic mouse and give it the ApoL1 gene. And if you give it the G0, which doesn't cause kidney disease, that's the version that all white people have, these mice don't get kidney disease. But if you give them G1 or G2, they get FSGS, focal glomerular scarring, protein in the urine, and it shows that these risk variants are not just associated with kidney disease, they cause kidney disease. Well, this is a transgenic mouse model with ApoL1 kidney disease that got an antisense oligonucleotide. And this is the G1 risk variant mouse. And I want you to see, if you just don't stimulate the cells, there's no protein in the urine in this mouse. But if you turn the gene on with interferon, which upregulates the gene, just like people with HIV nephropathy upregulates the gene, they get tremendous proteinuria, these mice. The albumin creatinine ratio goes way up. But if you give them the G0 variant, which doesn't cause kidney disease, and give them interferon, they don't get kidney disease. So this proves that G1, when you turn on that ApoL1 G1, it causes kidney disease. Well, this is what happens if you give them an ApoL1 antisense oligonucleotide. No proteinuria at all. So this is that ApoL1 G1 transgenic mouse. If you don't give them anything and you give them interferon, the protein in the urine goes up. If you give them a non-specific antisense oligonucleotide directed against some other gene, heavy proteinuria. But when you give them an antisense oligonucleotide that binds to the ApoL1 messenger RNA, no proteinuria, prevented the kidney disease. By the way, the higher dose of the antisense oligonucleotide you give, the more knockdown of the messenger RNA you get in cells of the kidney. Low dose, higher, 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 you're knocking down the messenger RNA, making less protein. This is the liver. As you raise the dose of the antisense oligonucleotide, you make less of the ApoL1 in the liver, and this is the plasma ApoL1. This is what protects you from African sleeping sickness. As you reduce it with the antisense oligonucleotide, the plasma ApoL1 goes down. So this is another clinical trial of an antisense oligonucleotide called AZD2373. They gave this antisense oligonucleotide against ApoL1 to 32 healthy Black men. And they were dosed weekly with a shot subcutaneous injection for 6 weeks, followed 9 more weeks, and they measured the plasma ApoL1 levels. And it's very exciting. This is the placebo group. The plasma ApoL1 doesn't change at all. This is the low dose group. After a few weeks of dosing, the ApoL1 in the blood starts to drop. Higher dose, it drops more. The highest dose, you suppress the ApoL1 in the protein in the blood tremendously. Well, remember, we know in the mouse that when you reduce the ApoL1 in the plasma, you're also reducing it in the kidney. So this trial showed in healthy people, the ApoL1 antisense oligonucleotide reduces ApoL1 levels. And I'm very excited to say that Wake Forest and I now lead a new phase 2 clinical trial by AstraZeneca called the Appreciate study. And we're giving that same antisense oligonucleotide, AZD2373, to African Americans with kidney disease and ApoL1 high-risk genotypes. So just like the Vertex study is looking at a small molecule inhibitor, the Appreciate study is looking at an antisense oligonucleotide. So I'm done, but I just want you to know, when you go to clinic and you see a family clustering of disease, think about a gene. And when you know that your treatments are not effective and lowering blood pressure doesn't do the trick, you can change medicine. So we were part of the ApoL1 discovery. We're changing kidney transplantation with the NIH Apollo study, and there are many trials to treat native kidney disease. Small molecule inhibitors, there's 2 different ones being tested, one by Maze Pharmaceutical and one by Vertex, and there's the one antisense oligonucleotide by AstraZeneca. You can get your patients in Danville enrolled in these studies if you find the gene. So my last slide is 2 coding variants in this one gene called ApoL1 directly cause multiple non-diabetic kidney diseases in African Americans, solidified glomerulosclerosis incorrectly blamed on high blood pressure, FSGS, collapsing glomerulopathy like HIVAN and COVID-associated nephropathy, lupus, sickle cell, failure of transplanted ApoL1 high-risk genotype donor kidneys. And now we have directed therapies against the protein messenger RNA and signaling pathways in clinical trials that provide great hope for our patients. So, Dr. Moore, Dr. Starling, Mary, first of all, thank you for letting me tell this story. It's been a 35-year life story for me. This is all I think about. And coming from talking to those Black families with multiple people on dialysis when things were so hopeless and promising them in 1992 we'd find the gene and develop cures for future generations of their family, in 2025, I think that's happening. Mike, I'm happy to open it up for questions.
Dr.
I have
Friedman,
questions.
there is one question in the chat, or two. Dr. Council was wondering, in your experience, will most insurances pay for APOL1 testing?
Well, if it's done as part of the kidney transplant evaluation for a living donor, it's paid for as part of the donor evaluation. I can't speak to reimbursement for APOL1 testing and others depending on insurance companies. I'm sorry, I just don't have that information. And I think that's changing rapidly every day of the week.
And Dr. Dupre was wondering, does acute nephritis caused by group A beta strep affect patients with the APOL1 mutation more than patients without that mutation?
Yeah. So I think what we're talking about is post-streptococcal acute glomerulonephritis, PSAGN, if I'm not mistaken, and there's no effect of APOL1 on that disease. This is a slowly progressive, other than that collapsing glomerulopathy from HIV and COVID, which can cause acute kidney injury, rapid progression of kidney loss. Those other diseases all take years and are chronic. So no, beta hemolytic strep is not associated with this disease. Thank you.
Any others, Mary?
No, that's it in the chat right now.
Mike,
Anybody on the,
Jim, Barry, that
ahead.
was a great presentation. And I'll tell you an old story. Back in the 80s, the Mid-Atlantic Renal Coalition, which was responsible for overseeing quality of dialysis in Virginia, West Virginia, Maryland, and DC, noted a marked difference in mortality in dialysis units. We felt pretty good about it. We were one of the largest dialysis units in that network with one of the better survival rates. But when you started looking at the data, it was the demography of who you were dialyzing. If you were dialyzing an older white population with cardiovascular disease and diabetes, your mortality was going to be high. If you were dialyzing a younger Black population with renal disease, your mortality was going to be low. Of course, biopsies were rarely done because there was no proteinuria or hematuria in the patients. But that's an aside, okay?
That's not an aside. That's directly related to APOL1. So, Jim,
Yeah.
First of all, I'm honored that you came to my talk tonight. Thank you. It's great to see you again and talk to you. But, APOL1 causes kidney-limited disease, focal segmental glomerulosclerosis, solidified glomerulosclerosis. Those just affect the kidney, not like that old white guy with diabetes and atherosclerosis everywhere. So we have published that people with APOL1 kidney disease live longer on dialysis. So these are young Blacks with kidney-related disease. You're absolutely right. This is why Black patients live longer on dialysis than non-Black.
Yeah, we've had 20-year survivals by young Blacks on dialysis.
Yeah. Well, the other thing we talked about, access to care, socioeconomic factors early on, there was a question about that. And your atherosclerosis, the genes that predispose to that are enriched in the European population. We actually showed that African ancestry protects from cardiovascular disease. And then you might say, well, Dr. Friedman, that's ridiculous. Black people have more heart attacks than white people. That can't be right. Well, Jim's point was Blacks on dialysis live longer than whites. They have equal access to care. Medicare pays for their dialysis. Suddenly they have health insurance. If you go to the VA where everybody gets treated the same, and you go to Kaiser Permanente, an HMO where everybody gets treated the same, black, white, purple, green, Blacks have 50% less heart attack at Kaiser, at the VA, and on dialysis. And in the general population, Blacks have much more heart attack. That's because of lack of access to care. But once you equalize care, the biology comes out. We published in this, African ancestry protects from atherosclerosis. So it's unfortunate that the environment is muddied by lack of access to care.
Dr. Freeman, let me ask you something. You showed us the lady on dialysis who was early on thought to be hypertensive and it was incorrect. If you have the gene, either one copy or two, is it known what triggers the gene to start the kidney failure, or it just spontaneously happens at one day?
Yeah. So, I tried to keep this talk at a primary care level. I will tell you, we don't know the triggers in everybody. And I can tell you for sure, high blood pressure is not a trigger because you see the data, lowering the blood pressure doesn't protect kidneys.
Right.
And Mike, you probably participated in SPRINT and some of those other studies. I feel certain your group participated in those. But it's not high blood pressure. But things like HIV infection, COVID infection, giving the medicine interferon causes kidney disease only in people with a high-risk genotype. Sickle cells, anti-nuclear antibodies, those are all triggers. But in most people, we don't know the trigger yet. We're
What the
looking.
trigger is.
And as the kidneys get weak, what happens to anybody with kidney disease? The blood pressure goes up secondarily
Sure.
to the kidney disease. That's why they're mislabeled. Yeah.
Let me ask you another one. For the donor giving the kidney, if the donor is otherwise healthy but has one or two copies of the APO gene, do they have more kidney failure as a single kidney person after the
Absolutely.
donation?
Great question. So first of all, I would say we should be focused in the United States on two copies of the risk variants. The one copy only causes kidney disease in Africa. In the United States, one copy really doesn't cause kidney disease. Two
Okay.
copies does. But all the data that's been done in people who have donated that were Black, and they looked at their DNA after they donated, the people with their two risk variants, high-risk donors, were much more likely to have chronic kidney disease after donating, and many of them
Right.
developed, these are people that were thought to be healthy enough to give up a kidney. And later in life, they needed a kidney because they got end-stage renal disease. So this is
Right.
important. Doctors often get that 25-year-old kid who says, my 60-year-old dad's on dialysis, I want to give him a kidney. And you say,
Yeah.
you're Black, you got a family history, and your dad, I'm a little worried about you. He says, I don't care. I want to give a kid. I love my dad. If you see two risk variants in that kid, you don't know what he's going to look like when he's 35
Right.
or 45. We are very hesitant about taking those kidneys. Now, if it's an African American living donor that's 60, doesn't have kidney disease, protein in the urine, normal blood pressure, we might take the two risk variant kidney. But young people, yeah. We won't take a young person with two risk variants who's Black because they need their kidneys themselves. Now, by the way, the therapies we talked about, the small molecule inhibitors like inaxaplin, the antisense oligonucleotides, they may work in people who get a kidney transplant. So you may get a kidney from an APOL1 high-risk donor. The kidney starts to get weak. Maybe these medicines will save the kidney. Maybe if you donate and you only have one kidney and you start to get kidney disease, the medicines may help the donor. So there's lots of room to test these drugs in the future.
Absolutely. Are there other questions for all the good folks on the call tonight? We've got large group, 60 plus primary care, a lot of primary care folks. I know we have some people that are in renal care service areas. Any last minute questions for Dr. Friedman? We're coming to the close of our time. Okay, well, Dr. Friedman, we want to thank you for a terrific presentation. We are, I think, so fortunate to have these insights, which I really don't think most people in healthcare actually have all this insight yet. I know when I read your article, the most recent New England Journal article that came out, I thought, wow. And I mean, I've been doing this for, along with Dr. Starling, for a lot of years. And I get the literature, I get the JSN every month and whatever. But suddenly the clarity just kind of struck me. Wow, this is super duper doing. We used to teach, we as recently as a few months ago, that if they had hypertensive eye changes and early renal impairment and no major proteinuria, there was hypertension, that the fundi told the story. But the fundi could be because the pressure went up after the APO triggered the renal failure. It's kind of like the egg and the chicken. So I think that's another primary care impact that you have to now put a caveat when you're talking about hypertensive retinopathy as a diagnostic help, as we used to teach, that if you had diabetic eye disease and proteinuria, you had diabetic nephropathy. Well, I don't know if that's going to be true yet or not. But one last question. So really, there's nothing extra renal that having the gene promotes. I know that one of our first questions tonight was this the bad APO1 that you have in the lipid world?
Yeah, I think that question was about something like lipoprotein little a, LP little a or something.
Yeah,
Yeah,
that's correct.
this is a kidney failure gene. It doesn't cause heart disease, stroke, and no, it's renal limited disease. And Mike, I would end up by saying if somebody has longstanding diabetes and diabetic retinopathy and diabetic neuropathy, probably they have diabetic kidney disease too. The fundi still tell the story for diabetes. Yeah.
Absolutely, absolutely. One thing I would mention, if you're in the, some of you are not, but the majority of folks on our call tonight are Sovah Healthcare Associates, as it were. If you want to draw these, I would recommend you check with Sovah Labs. We have a world-class lab service, and I don't know about the APO1 gene either, but I know that the folks there, you can reach out to them, and they will find out for you and help you with that as far as how to get it drawn and all the financial aspects. So let me thank you again, Dr. Friedman. Wonderful job, Mary. Thank you for your help. And I don't know if Van's on the call. If she's not, my wishes to her for helping with the nurses CE. We hope you'll join us back again 2 weeks from tonight when Dr. Pawa from the Johns Hopkins Hospital Hospitalist program will be talking about explaining what value medicine is, how utilizing it provides safer and greater patient care, and also helps the health of the healthcare system. That being said, as I remind our residents when I gather with them, please be careful out there, and we look forward to seeing you back. Have a great evening. Good night. Bye-bye.
Thanks, Dr. Friedman.
Thank you all. Thanks, Jim, for joining. Good night.
Good night.